Hello and welcome to the NBNU podcast. Today we're focusing on a topic that has been coming up more and more in conversations with members, and that is scope of practice. This conversation comes out of work that began following a motion brought forward at last year's AGM, where members called for a deeper look at scope of practice and how it shows up across different areas of nursing. In response, a board subcommittee was formed to explore these questions more closely. With representation spanning nurse practitioner, registered nurse, and licensed practical nurse roles, this committee brings a broad, practice-based understanding of member realities, care environments, and system pressures. Today, we're joined by members of that subcommittee, Raelyn Lagace, Laurie Leger-Lester, and Angela Miller, to talk about what they've been seeing and discussing through that work. Thank you all for being here. As part of your work, you've been looking at how scope shows up in real settings and how different that can feel depending on role, environment, and the supports around you. So this is really a chance to share some of those insights in a way that's helpful for nurses across the province. Maybe to start, when you think about scope of practice in your day-to-day work, what does it actually feel like?
That's a great question, Joanne. I was thinking about this, reflecting on this last night, actually, and I would say in my role as a clinical lead, signing and prioritizing clients is part of my role. And of course, there's a significant overlap between roles, right? But we also recognize that there are distinct differences, for example, in autonomy, complexity, and depth of assessments. So we work in an interdisciplinary team here at the clinic, Addictions and Mental Health Clinic. And yes, assignments are certainly done based on scope of practice, but in addition to competence of the provider. So I may have a fairly new RN, new to the clinic, who we could easily say that the role is within our scope of practice, but we've got to be able to build up her skills, right? And which will allow her the competencies and confidence to fulfill the role. So it can look different. We have to have judgment, I guess, initially is what I'm saying there.
For me, what it looks like on a daily thing is, it's what keeps us kind of grounded. Our scope of practice is what we can do, but it doesn't mean that we can, it kind of anchors us, but it doesn't mean that we're going to use our scope of practice everywhere we are. I mean, we have to be where our scope does overlap some with the registered nurses. We have to be very aware of our scope and very aware of our policies within our place of work. So it needs to. We need to know who to go to when we have a question, but we do need to know what we're allowed to do and where we're allowed to do it.
I would say, in my role as a nurse practitioner, my role looks a lot different from that of the RN and the LPN, especially in the program that I'm working within currently. I am the clinical lead. I am the go-to person. I am the person that generates the work. And so for the people working with me, it's important for them to understand their role, and that can look different from program to program, as was already stated. But the important thing is, I think for all of us, as an NP, my role encompasses all of the other two plus. And, it's already been stated, we need to understand our role, our scope, and work within that based on our comfort, our knowledge, our experience. And so that will be the same in regards to a nurse practitioner. A nurse practitioner coming into my program today wouldn't have the knowledge or the experience that I have in regards to the program that I'm working within. So they would have to build up on that and understand and have extra education in order to work within their scope within my program.
So I'm curious for the three of you in your own individual roles, and as well, Raelyn, as a nurse practitioner, where you say you are the task giver. What does autonomy look like for each of you in completing your individual roles, but also for you, Raelyn, as you provide those tasks to other RNs and LPNs?
So I'm an independent provider. I work autonomously. I can diagnose, prescribe, refer, basically do much of what a family physician can do within my scope. When I'm delegating tasks or, generating those tasks, then it's definitely going to be within the scope of the provider or of the nurse that I'm working with. So I work with an LPN within my program, and her scope would be different than it would be of the RN within my program if we had an RN, just because of the nature of our program. So I guess when I work with in different areas and with different disciplines, then that might look a little different because their knowledge, their experience, the policies that are present would all help dictate what they are able to do.
Yeah, and I can share, Joanne, the role of the RN in community settings. We certainly have more independent autonomy, and so we would proctor with a higher degree of independence, clinical judgment, and we can do this. We can offer this type of care without the presence of a physician. In terms of the RN role, it's very much leadership, right? So we would, in terms of consultation, if we're looking at the collaborative care model, and, an LPN would, although they can also work autonomous, and Angela will speak of that, it's the availability of the RN or nurse practitioner for the LPN to be able to consult with, right, if needed.
Yeah, like Laurie said, as the LPN, we can work autonomously also, but it looks different than the registered nurse, because we are it's like a team model for us. Like our patients that we look after are normally stable, less complexity, whatnot, but it's not always the case. Sometimes our stable patient turns to a unstable patient. So we have to know that when that happens, what do we do now? We stop and we, if we work with an RN, we're going to talk to them. They might, depending on the complexity, they might take over completely, or they may just take over partially. So we may still be the primary on the looking after the patient, but we have that backup from our registered nurse colleague. So that's where it goes, because it's not easy to find stable patients these days. But we have to know that when they take a turn for the worse or become an unstable patient, what do we do and who do we reach out to? And it's our RN colleague, if that's who we have. If not, if it's a nurse practitioner, then we go to them. If not, if it's a doctor, then we'll go to them. So.
And for each of you, I guess this next question is twofold. Did your scope feel clear early on when you first began in the environment you're in now, or even when you first began your career? And at what point does it start to feel unclear?
When I started, we did a lot less. What's within our scope? Well, it wasn't that it wasn't within our scope. It was what I did when I started is completely different than what I do now. What I can do. Policies have changed. Our scope of practice, pretty much the same. We had the education for the medication and whatnot. But when I came out, we weren't doing it. Do you know what I mean? I had the education through the college, but we weren't actively doing it. It was kind of at a time when it was changing more so, so I was pretty clear with my scope. Now it's a lot more moving parts. And again, depending on where you work and your education, your experience, because there's a lot of advanced competencies that you can do. Like just because an LPN can give a certain medication or insert an IV, start IV medications, you need the education behind it. So if it comes with a advanced competency, your scope might say you can do it, but it doesn't mean that you can do it unless you have that education, extra education to go with it.
Yeah, Angela, you made a good point about complexity. And, my experience in the community, I would say that nursing roles in the community haven't evolved as quickly as the complexity of the clients we're seeing, right? So, in terms of scope and all the things we're talking about, I see us evolving with that. And I think it's important to note that, when I think of the conversations I've had with colleagues and we're talking about scope and, trying to clarify roles and what have you, we're seeing practice environments that aren't set up the same way as inpatient units, right? So, when we talk about, the overlap of some roles and we talk about the practice environments, when we start asking questions, that speaks to me because it speaks to me in ways that clearly identifies that we are confused about role clarity, and maybe there's questions on clinical supervision and orientation and competency, those sorts of things, right? So although, we're working through this, and in my community setting, it can be challenging, it's almost expected given where we are today.
And I think, I can pick up on that in regards to my role as a nurse practitioner. Laurie, when you talk about complexity, when I first became a nurse practitioner, I was dealing with less complex patients. My role was very clear in what I was able to do and what I was not able to do. And it's still very clear today. The role has changed, though, in the sense that the scope has broadened. And I am no longer dealing with mainly stable patients. Those don't exist, as was previously mentioned. So therein lies the challenge, because we are in a health crisis and we have a shortage of specialists, of family physicians, of nurse practitioners, of RNs, of LPNs. We have a shortage of a whole bunch of providers and healthcare workers, which makes the role in caring for these patients much more challenging as a result of accessibility. And that's what I talk about. I mean, when I talk about nurse practitioners, I have a patient in my office that I know is very complex, very ill, where in the past I may have been able to call up a specialist and say, I have this in my office, and they'd say, send them over. That doesn't exist anymore. So it's deal with what you've got in front of you to the best of your ability. And, eventually the patient does get seen by the specialist, but the specialists don't care for the patients the way they did previously because they don't have the time either. So it's a vicious cycle that is playing to the reality of what we're living today with the complexity, the challenges as providers.
And in terms of that clarity of scope, I'm wondering if any of you have an example of a time when it wasn't totally clear. You were not sure if what came across your task list was something that you were able to do, something that was in scope, and what you did in that situation. And then furthermore, what maybe what you did wasn't what you would recommend now, but what should someone do in that situation?
Yeah, that's another great question. And as my position with the Local 31 president, I have the opportunity to talk to some of the nurses within the clinics. And we ran into a situation a few weeks ago where, the team, they're a team of LPNs. They have an RN who, they can consult by phone. Again, I know they're working with what they have currently. It may not be ideal, but that's what they have to work with. So the question around scope and, what would I do if, again, complexity increases, acuity, that sort of thing. So we talked about that and what would you do? So, my recommendation would always be, pause, right? Like, let's assess the situation. You've got great clinical judgment, right? Pause. Okay. Is the client in immediate danger? just take a snapshot of the picture. If they're not, this gives you time then to base your next step on, okay, I don't have somebody readily available to me on site, but do we have policies and procedures that we can follow? Do we have, clinical order sets, pathways? Is there another team member? Maybe it's a physician. Maybe it's a social worker. Can I collaborate, right? I think the key to this is that, yes, it's important that we know our scope, but when in doubt, it's having the ability to make a clinical decision based on, safety and all of those things, right? It's not about, did you make the right decision? It's about, did I make a sound judgment in this particular case?
And I think we also have to consider our standards of practice. Are we meeting those standards? And we also have to consider the liability that comes with the decisions that we're making. The policy may be there. The hospital may write that policy. It might be within that community health center, that clinic. But at the end of the day, the liability lies on the individual healthcare provider, the individual nurse. And so when the situation is not as clear as it should be, we have to go back to those standards of practice that we are legally held accountable to and ask ourselves, are we meeting those standards? And if we are not, then we have to, as Laurie mentioned, pause and assess, but think that at the end of the day, I am responsible for what I do. So what I do is going to be very important moving forward with this situation that I'm currently in. And so I think that is something that has to be kept at the forefront whenever we are practicing and the scope or the situation is not as clear as it could be. And you have to think, what would a rational, reasonable person do in the same situation and make the best decision at that time? But again, keeping in mind the liability that lies with you with those decisions, because regardless of what decision you make, you are the one that's responsible at the end of the day.
That's true. We are responsible for what we do. I mean, I've had people reach out to me about medications, certain ones, high risk, asking if, or being told that they were going to have to hang them, administer them. And, I said, absolutely not. Like you had, so they called me because they wanted some support. So, but I said to them, absolutely not. If anybody questions it, give your, you gotta be okay with saying, I can't, no, I gotta stop. Gonna make sure that I can do what you're asking me to do. And, policies and procedures. Yes, we have to make sure that first and foremost that we're allowed to do it. But then, like Raelyn says, we have not just that we're allowed in the policies, but, should we do it? And my goal out of this whole with the scope is to make new nurses, RNs, LPNs, just okay with saying no to whoever's asking them to do it if they question if they can do it or not. Some have a hard time saying no when they know it's not within their scope. Hopefully they still say no, but people have a hard time speaking up. But it's your license on the line. It's nobody else's, because it's your responsibility to know what you can do, what you can't do, or who to reach out to if you need help. But at the end of the day, it's your professional license, and we have to protect that. And anybody tells you that that's not important, then you have to know what's important.
So if I'm an early career nurse, or maybe I've just moved to a new work setting, I listened to this podcast today and I realize I don't know my scope. What is the one thing you want them to know? What should they do?
I would highly recommend that the nurse, take on that responsibility and, dig in. Part of the committee, we reviewed the intraprofessional collaboration guideline between, it was done by the associations for the LPNs and the RNs. Fantastic guidelines. I would also recommend speak with your colleagues, right? Like, again, the association bodies, they're there, there are licensing bodies and, scope. We've talked about that, protecting our licenses and things like that. But I would just say it's our responsibility. But I also think it's important to recognize that the employer plays a role here as well, right? Providing safe environments for nurses to work in. And when I speak of policies and things like that, that is, to me, that speaks safety, because someone has put the work into that, right, to create these pathways for us. It doesn't negate the need to know our scope, but, practice environments that aren't properly staffed, that, there are no procedures and policies and things like that, that has a negative impact on the nurses working in those environments, right? So it's twofold. It's both our responsibility and our employers.
Yes. When we don't know our scope, if we arrive into a new environment, we have to know where to go to find the answers. And that may be the college, that may be the manager, that might be a colleague. But when you don't have direction, then you have to find that direction. And the employer has a role in providing some of that direction as well. And sadly, sometimes because of staff shortages and things like that, we're put in situations that maybe we shouldn't be in. And there might be a sense of false sense of protection from maybe somebody else saying, oh no, you can do this, or this is okay, or whatnot. But at the end of the day, if you have nowhere to go or you're not sure who to check with, then check with your college, the College of Nurses of New Brunswick, or check with the LPN Association if you're an LPN, because they are the ones that can tell you, at least give you some guidance in what you should or should not be doing. And I think it's important also to mention that if you do feel that you are in an unsafe situation and that it's a workplace issue, then maybe you have to speak with your union representative, because that person can also potentially provide you some guidance.
Kind of like what Raelyn said about being put in situations where you feel a false sense of security almost. Maybe that, you have to do it because they want you to do it, or like, when you get staff shortages and or in ER fast-paced environment and everything's going crazy all at once. But again, you have to just be able to know what you can and cannot do, and employers will put you in sticky situations and not really care about it. So you can go to their policies and procedures, but you can't always go. They'll try and get you to do things you're not supposed to do just because it makes it easier for them. So
acting with confidence in this context doesn't mean feeling positive about yourself. It means making justified professional decisions grounded in competency and safety, right? So that's what I heard you say, Angela, right? It's about having that critical thinking ability.
A lot of times working with doctors don't always know the difference between us. They really don't. They're like, I've had them ask me, so what's the difference? But just because, they know what they do, they're not worried about the rest of us. But, I've had doctors say, oh, can you do this? And I'll be like, no, we'll have to get somebody else, because that's not within my scope. That's not what I do. And like I said, because they'll ask because they don't know. It's not that they're being malicious. They just don't always know what an LPN, for example, can do, where some of the things are similar. But you have to, just because they're a doctor, you have to be, doesn't mean you can't say, okay, with confidence, no, that's not something I'm able to do. So we'll have to find somebody else, and, I'll go get my colleague or whatnot.
So essentially, the college is the authority for defining the scope. The college, I should say, previously known as the Association of Nursing. And the union is really here to support you for how that plays out in practice. Does that sound about right?
Yes.
Would any of you have Any examples of one thing you wish you had known earlier about scope?
I guess for me, it was, I always felt it was important. I came out of, my LPN a lot, a little bit later in life than some go into it. It's like in my 30s. And so I knew that was important, but I wished I would have known how murky it was going to get. I don't know if it would have helped me any, but
maybe just knowing earlier that you could say no would have been helpful even, right?
Yes. Yeah. Well, I was always okay with saying no in that regard, but you know what I mean? But
yep,
because I'd already had 3 kids, I said no a lot. So I was pretty used to saying no. But I could see if I went into becoming a licensed practitioner nurse earlier on, a younger age, I can't say that, not that it has anything to do with age, but just experience is what I mean. Maybe with less experience, maybe I wouldn't have been as aware of my scope or knowing how important it really is, and how, as the years goes on, it's even more important to know because of all the things that have changed. And I think when I came out and I was, when things were changing and the scope was opening up and policies were changing, at that moment we had to know, like, we were learning this is what we can do, and that, do you know what I mean? Like, so every step we took, it was a little bit more and more experience and seeing what, because we were getting new things that we could do and opening up of our scope. So, but it could have been quite complicated, with coming out now and having so much, it's so different, I mightn't feel the same.
For me, I wish that I had a better understanding of the scope of practice for my colleagues, not just my own. That's sort of what I've learned, especially the last couple of months. And, when I think about that, with that knowledge, we work so much better together. We're more effective, and we really provide the best possible care to our clients and our patients. So that's probably the biggest lesson for me in this journey.
I think in addition to that, what Laurie said, I agree. I think for myself as a nurse practitioner, what I wish I would have known when I first began this journey was where it was heading. I don't think I saw when I first started 15 years ago down this road into my journey that I would be able to admit to hospital and care for acutely ill patients. What I would say to that is I don't know whether it would have changed my decision or my trajectory. I can speak to that today, though, and I can honestly say that I do not have the competency or education to be able to care for patients that are in hospital who are acutely ill. My education was focused around primary care and caring for patients in the community. I personally will not be admitting patients to hospital, even though it is within my scope or that my college or my employer tells me that I can. And I think it goes back to what we've been talking about throughout this whole podcast. And the fact is, just because someone tells me I can doesn't mean I should.
So I think one key takeaway is that understanding your scope isn't about limitation. It's really about protection and having confidence in your role. And if something doesn't feel clear, you don't have to figure it out alone. So we go to the College of Nursing New Brunswick, we talk to colleagues, or we go to our union. Thank you everyone for being here. We appreciate the expertise. The work that we've been putting in over the last few months on the subcommittee is coming together. And to everyone listening, thank you for being part of this conversation. And I think conversations like this are one way that we strengthen the nursing as a profession by understanding each other's experiences and the reality of the work across the province. Please stay connected and watch for updates on our website and social channels. And to all of those working in healthcare, thank you for everything you do for the patients, residents, and communities of New Brunswick every day.